I'm going to teach you the essentials of one of, if not the most productive solo dental practices in the United States. That's right. According to the studies, our practice is one of, if not the most productive dental practices in the United States. Even though our practice is not based on productivity, it's based on the product, but I'm going to teach you our system. I've never had a practice consultant come into my office. As I said, everything is based on producing the highest quality product for the patient. And this is how we do it. This made sense to me. Back in the day when I was starting my practice, my question to myself and my staff was, how can we, in the beginning with the patient, give them enough information that they clearly understand their presenting dental condition and their treatment options? We're not trying to talk anybody into anything. That's a mistake. Don't ever do that. Sell has no place in healthcare. But we do have an obligation to our patients when they've had the courage to pick up the phone and call our office. Imagine how much courage that takes for a patient to call a dental office. We have an obligation in that initial interaction, or the first couple of interactions, to give that patient a clear understanding of their presenting condition and their treatment options. So this is the CARD Comprehensive Practice System. There are three essential parts of the system. The new patient pre-exam interview, which takes place in my private office. The new patient comprehensive examination, which takes place in an operatory by either the initial parts of the exam take place with my dental assistant or with a dental hygienist. 99% of the time it's with my long-time dental assistant. And then finally, the new patient consultation, which is at a separate appointment time in my private office. So this is where I do the new patient interview. Sitting in my private office, I've got my computer, I've got a notepad. I always put the patient sitting on this couch, so I'm not looking across the desk at them. Now in the consultation, they'll be sitting right here. So what happens at that new patient interview? You know that song, Getting to Know You, Getting to Know All About You? I want to know who's connected to the teeth. If a spouse is with the patient, most of the time I'll have the spouse also come in and sit right here on the couch with the patient. Some of the questions usually the patient is nervous, so we just have chit-chat. I'm from West Texas, so I love a good story. And many times I'll tell a story initially just to let them calm down and get settled. And then I'll say something to them like, what's your story? Which is a very open-ended question, or tell me everything. I've got nothing but time. And it's amazing what people will tell you. They'll tell you about their past history, what they don't like about dentistry. Sometimes I'll say, is there anything you don't like about dentistry? It's amazing the magic of being heard. When that patient feels like you're hearing what they have to say, their concerns, the things they like, the things they don't like, what's been a problem in the past. And not only are you listening, but you're writing it down, and periodically I'll recite it back to them. Here's what I heard you say. Is that everything? They'll say yes. So we'll go through that, and then I'll say, tell me how I can help you. After we've had just conversation for 5 or 10 minutes. And these occur in my office at 8 in the morning or 10 in the morning. I rarely have a new patient interview or exam in the afternoon. And there are reasons for that that we'll go into as we delve deeper into this CARD Comprehensive Practice System. So while my assistant is getting my morning patient ready, I'm having this interview. And after about 5 to 10 minutes of conversation, I'll say, tell me how I can help you. Or tell me about your dental issues. And then I stop and let them talk. And by the significance of that is they're kind of loosened up and relaxed because we've talked about other things, or I'll say something funny, or showing pictures on my cell phone, or different things, so it kind of takes their mind off dentistry. Now they're ready to talk, and they'll go through it. And as they go through it, I've got all these PowerPoint cases on my computer, and I may just be listening to them and not say a word, but click to these cases. I'm a visual learner. You can tell me anything, you can talk, and it's going to go right over the top of my head and mean very little to me. If you're a home remodeler and you're going to remodel my house, don't talk to me, show me what you've done. So the patient will be talking at this new patient interview, and I'll click to cases that are similar to theirs. And I won't say a word, except this young woman lived about 3 hours from here, and she was unhappy with the cosmetics of her teeth and the function of her teeth. She felt like dentists were just constantly patching her up. And that's what most of you do, because that's the model you've been taught. You have toothache practices. A patient comes in with a tooth and you fix that tooth. Then they come in with another tooth and they fix that tooth. Don't do it that way. That's not good for the patient, it's not good for you, and I'm going to teach you the comprehensive system. Remember, the comprehensive system doesn't mean you're doing something to all the teeth. It doesn't mean that. It means you're fixing the teeth that are broken, or you're improving the cosmetics. If I'm a home remodeler, I think this illustrates a comprehensive practice better than anything else. Most of you, as home remodelers, are taking your whole crew out to the house when the person calls and fixing the kitchen, because that's what the patient called about. I want to redo my kitchen. So you show up with your crew and you start on the kitchen just from the get-go. Not me. I'm going to show up with some measuring things, and I'm going to look at the whole house. I'm going to look at the foundation. I'm going to look at the walls. Do there termites? What's the floor plan? What's the wallpaper like? I'm going to pay specific attention to the kitchen, because that's what the person called about. And then once I've analyzed the house, I'm going to sit down with the patient, or the client. In this case, I'm home remodeling. I'm going to say, how do you feel about the rest of your house? Is there any plan for changing anything with the rest of the house? And if they say no, then we're just going to focus on the kitchen. But more often than not, they're going to go, oh yeah, I don't like the layout. I wish the rooms were more open. I'd like to knock out some walls. I don't like the wallpaper. It's important that you know those things about the house before you fix the kitchen, or you may waste time and money fixing the kitchen, and then the person decides to knock out the wall. Same thing, or change the floor plan, or change the wallpaper, or if you've got a foundation problem, you may not want to get into fixing the kitchen until they fix that foundation problem, because if it's shifting, the same problem that occurred for the client to get you out there is going to occur again, and now their problem is your problem. That's why I don't do big fillings. I don't want their problem to become my problem. When they bite down on that big filling that you placed, and they're standing in a group of people that you would like to have in your practice, and they break that tooth and say, oh my gosh, Dr. Smith just fixed that tooth last week. Well, you didn't fix it, you patched it up, but their problem is now your problem. So she didn't like the cosmetics of her teeth, also had decay issues. Nobody had ever told her what caused it, how you could keep from having it again. You see these giant fillings in the teeth. Even though these are tooth colored, you can see the size of the fillings. We lost this tooth because big fillings leak. When you have big fillings in the tooth, you're either going to break the filling, you're going to break the tooth, because there's nothing holding this side of the tooth to that side of the tooth, or you're going to get decay underneath it eventually. Same thing on the bottom in the mandible. We lost that tooth. It had a big filling with a root canal. Big fillings here that are broken down, and what her dentist was doing was just putting out fires. When she'd have a problem, he'd put out the fire. Now, if I tried to describe this to a patient, guess what? They ain't going to get it. they can't understand it. But if you show them the photographs after showing them books like these that have before and after pictures in them of decay, leaky fillings, cracked teeth, a little water damage here. See leaky fillings with the decay underneath them, decayed into the nerve of the tooth. So they've seen this ahead of time. Cracked teeth, everything's in this book. Then when they look at their teeth and they see these cracks, they know that this tooth is about to do what that one did. So these are porcelain veneers on her front upper anterior teeth. We didn't need to veneer the lower teeth. We just bleached them and did a little bonding of the chipped incisal edges on the lower anterior teeth. This is not overkill, but every one of these teeth with these giant fillings, this is a bridge. We didn't do an implant because of the proximity to the sinus. We would have had to do a sinus lift. So this is a bridge, and these are crowns. See the size of these fillings and decay between these teeth? Same thing on the mandible. This is an implant. We lost that tooth, but we have these big fillings. You put a crown on top of them to hold the teeth together. Patients understand that. When you show them this picture of these cracked teeth and this broken tooth, and you say, the reason that happened is because there's nothing holding this side of the tooth to that side. So when the person bites down right here, it breaks. It needs something on top of the tooth to hold the tooth together. Now this was a small filling. Good tooth cut structure around it. So a filling was appropriate for this tooth, and we replaced that filling with a tooth colored bonded composite. Patients understand it if they can see it. Patients understand it because they can see it. They can see it in their own mouth. So this is a comprehensive case. See how nice the gingival tissue looks there. Use the techniques we've talked about with cementing porcelain veneers and crowns so that the gingiva is perfect every time. So anyway, while I'm talking to these patients sitting on the couch at the new patient interview, I'm going through these cases. This young man was from Tennessee. These are in the dentistrymasterclasses.com comprehensive card teaching system. So subscribe to that. And he'd been told he was going to lose his teeth. You can see all the decay everywhere between all the back teeth. His mother was just sobbing. A dentist had seen a seminar I'd given and said, go see this guy. So first I had to do a periodontal crown lengthening. Now remember, that involves alveolar crest removal or recontouring as well as gingivectomy to get above the decay and below the decay. This is after a week of healing. Amazing how fast the gingival tissue heals. And then this is the final restoration. Veneers on the anterior teeth. I was able to save all the teeth. Crowns on the posterior teeth where you had the large fillings in the decay. Crowns here. Got a moderately arched lip in repose. So I'm showing these cases to patients as they're sitting there at the new patient interview. And it's based on kind of on what their condition is, but more than anything else, I want that patient to see that I can fix anything. And they're going to look at these and think, oh my gosh, if he can fix that, I know he can fix mine. So they're looking at these cases and they're thinking, so many times they'll say, I'm sure I'm the worst case you've ever seen. And I'll say, no, you're not. And I'll show them these cases, and then they feel really good about their condition, or at least feel like they're not hopeless. This lady just been patched and patched and patched and decayed, and she was going to the dentist and he was still patching her because it's the managed care HMO high volume network. You're not bad people for doing that. It's just a hamster on a wheel. You're trying to buy watermelons for $2 and sell them for $1 and make it up in volume. It doesn't work for you or the patient. You hate dentistry. The patient's not happy with the work. You're having to redo things all the time because it's breaking down. We never have to redo something. It works the first time. You can see missing teeth, patch on patch on patch. And she was from Austin, a town about 2 hours from here. So think about how her life has changed looking like this versus looking like that. So on and on. I go through these cases. I've got everything from implants to full mouth reconstructions to sinus lifts to you name it. The stuff we're going to be going through in the dentistrymasterclasses.com. So don't miss that if you really want to have some fun and take it to the highest level. So I'm not saying anything. I'm just going through these cases about this fast with these patients sitting on the couch, and they become hypnotized. See, this is a crown lengthening issue, and the girl had 2 veneers on her lateral incisors that she was unhappy with, and she didn't really know why. They were gray, but the gingival line was off. So I've done periodontal crown lengthening surgery on that tooth, and this is a before and after. You can see what a difference a proper gingival line makes, and we've just re-veneered those 2 teeth. See the difference here, before and after? And it's subtle. You know, you're still going to go out on a date with this woman looking like that, but to her, it was like a mole on the end of her nose with the black hair growing out of it. She just hated it, so she loved her teeth here. This guy, another periodontal crown lengthening issue. A dentist had just placed 2 crowns on this young man's front teeth, and the mother, who was a patient of ours, brought him to see us and said, "Steve, look what they've done. He looks like not good." So what they hadn't looked at was the gingival line. Gingival line is critical in these high lip line cases. So I did periodontal crown lengthening, which again is alveolar crest reduction, as well as gingivectomy. And you can see how things are squaring up now with the pupillary line. Remember, the gingival line, the incisal plane, the lower lip, and the pupillary line ought to all be parallel, especially in a high lip line case. So this is after. We've veneered the 4 anterior teeth, periodontal crown lengthening surgery on the right side. Symmetry, symmetry, symmetry. You know, this gentleman was an old rancher. He lost all his upper posterior teeth, ended up losing those bicuspid teeth and that tooth right there. He just decay, lost vertical dimension, so he increased his vertical, lost that tooth right there, increased his vertical so we'd have more room for restoration. I did bilateral sinus lifts with bone grafts, implants, restored the missing upper lateral incisor with an implant, so these are implants with sinus lifts, implants with sinus lifts, all this, implants with sinus lifts. So veneers here, implants with sinus lifts here, crowns, veneers, occlusion. I can't wait to get into the occlusion, intra-articular facial pain dysfunction problems treatment. Here he is before and after. So what I'm trying to do at the interview, and it takes me about 15, usually the interview is about 15 minutes. I want that patient to feel like, man, I have found the right office. This is the dentist for me. If I can beg, borrow, steal enough finances to do this correctly, I know he knows how to do it correctly. So I don't want there to be any question in this person's mind as soon as possible that my office is where they want to be, and this is where they want to have their work done if we can work out the finances, because you're going to do more expensive cases because you're not doing the toothache thing anymore. You're doing comprehensive cases, and the patient is going to want to restore more teeth. So this is where we're going with this CARD comprehensive dentistry system. And that's the new patient interview. Then at the end of the interview, we have a handoff. And I always want to credential the person that the patient is being handed off to. So Pam, my assistant for 30 some odd years, is going to be performing the first parts of the comprehensive exam. And I'll say to the patient, Ms. Smith, Pam's going to do the first parts of your exam. She's an expert. She's been doing this for over 30 years. And so Pam will then do FMX, charting of existing restorations, and kind of an overview of what the patient's condition is. And we're going to talk more about the comprehensive exam in the next dental minute. So that's the interview. Pam is not diagnosing, she's just charting and getting an overview of the existing condition of the patient. Then we're going to co-diagnose together when I come in about 20-30 minutes after she's done the radiographs, the charting of existing restorations, and that type thing. Another thing I'll ask the patient at the new patient interview is, what do you not like about is there anything about your teeth that you want to change, either functionally or cosmetically? I'll also say, how do you feel about your smile? Now you want to be appropriate. If you ask somebody, how do you feel about your smile, and they go, fine, I'm just fine with it, then I'm not going any further. I'm not going to say, oh, but you could fix that smile. If they say they're happy with their smile, that's it. I'm not pursuing that at all. But if they say, I hate my smile, then that gives you license to say, tell me what you don't like about it. So in the interview, one thing leads to another. But what you're in general trying to do is form a relationship with that patient, show them what can be done so they know you can fix anything, and then find out why that patient has come to see you. In my opinion, it's very important that the interview does not occur in the operatory. That's a fearful place for a patient. I always do the new patient interviews in my private office. It's safe. I've got pictures of my family and other things on the wall. It's casual, and a patient will really loosen up and talk with you. If they're back in the operatory, that's not going to happen. Plus, I don't have my computer, so I can't show them those completed cases in an overview form. We're not taking a long time, but just to give them that feeling that I'm the one to do the work and that their case is not hopeless, that we've restored cases much worse than theirs, and that we can restore anything. You want to do the new patient interview in your private office or in a safe room. Today we talked about the new patient interview. Next time we're going to talk about the comprehensive examination followed by the consultation. We're going to also have a whole series on photography, which is critical to the patient moving forward with appropriate treatment. So look forward to those episodes.